All right, hello, hi. Hi, Dr. Adams, and we are here from Vios Pacific Northwest, and we have Taylor and Amelia here. And tonight we are gonna basically talk about fertility facts, specifically with Vios Fertility Institute. Next slide, please. So I am your host tonight, the hostess with the mostest. I am Dr. Shannel Adams. So and a little bit of background about myself. I am a doubly board certified OBGYN and reproductive endocrinology and infertility specialist, or an REI. I was born and raised in the Portland area. I actually was born at Best Kaiser, which is now the Adidas over there on Greeley. I did my medical school training at OHSU. I did my OBGYN training at the University of Hawaii, and then I did my fellowship training at the University of Cincinnati. I'm very happy to be back home serving the Pacific Northwest. In terms of things that really kind of connect with me, that are my kind of niche, if you will, is I really, really believe in fertility preservation. As a woman who did education first before starting a family, I also believe in, looking at the men, as you always know. Infertility, oftentimes it seems like it's just kind of a woman's issue or something. I don't want the men to be left out. We also do a lot of third-party reproduction, so that's building your family outside the box, if you will. Not just a traditional think about a man and a woman. We deal with all patients. And I'm also very, very passionate about more of a holistic care in terms of your care with fertility, dealing with, not only medicine, but your mind and body. In terms of other just fun facts, I'm a bar fanatic, so Pure Barre, love it, love it, love it. Try to do it at least 4 to 5 times a week. And my favorite days in the Pacific Northwest are either at Selby's Island, picking any kind of fruit if I can, or at the Pacific Coast. I love Cannon Beach. It's the smallest of the places. Next slide, please.
Okay, I'm Taylor. I am going to be the nurse at our Pacific Northwest clinic. I am also born and raised Pacific Northwest, about 30 minutes outside of Portland. I went to University of Portland to get my nursing degree and then went straight into fertility. And I've actually been in fertility for over 4 years now. And for almost the entire time, I've been able to work with Dr. Adams. It's been amazing. She's great. And just a little bit about myself is I live kind of in a zoo pretty much. I've got a dog, 2 cats, and a bearded dragon. Hopefully we're going to have some bearded dragon babies this fall and winter, so bringing fertility home with us.
And hello, my name is Amelia. I'm going to be the medical assistant, so you will see me in a more clinical setting. So perhaps during procedures with Dr. Adams or in the operating room, I may even get to draw your blood. So you'll get I'll get to know all of you very well while we're having intimate conversations over, the blood draw table. I, similar to Taylor, worked with Dr. Adams for the last 4 years as her medical assistant in the realm of fertility, and she has been a just utter amazing physician to watch to work with. I went to the University of Oregon, go Ducks, proud to see how we're doing in football, and I got my degree in anatomy and physiology. Fun fact about me, I had the amazing opportunity to live abroad in New Zealand, Fiji, and Australia for a year, which was unbelievable. Next slide, please. All right, so I'm just going to really briefly talk to you about Vios, which is just an incredible fertility clinic to participate at. Like you can see here, we really ensure that we use the highest standards in our fertility practices, and we have incredible results from our patients. Many other offices you'll find in the Midwest, so around the Chicago and Milwaukee regions. And one of the coolest things about Vios is we really are innovative and use really kind of avant-garde and amazing technologies. For example, our office in downtown Chicago has a technology called the Tomorrow Tank, and Vios is actually the only fertility clinic in the US that has that. And it's a really amazing cryopreservation tank. So that's really cool that we get to use that. And yeah, just like it says here, our main goal is to help patients meet their family planning dreams in one way or another. Next slide, please. So as most of you probably know, we are in the Vancouver area. We're actually right by the Salmon Creek office, kind of tucked away in a really cute little corner. I am a Portland resident currently, and so I can tell you that although Vancouver may feel like it's far away, I promise it's only about 20 minutes from downtown. It's a really great office, great space, and we're excited to hopefully get you guys in it and see how amazing it is and how great Dr. Adams is. Next slide.
All right, so tonight we're going to really talk about the top 5 things that you want to know about your reproductive health. So next slide, starting with number 1. So number one, you really want to understand your cycle. I mean, I think we talk about it, Taylor and Amelia, all the time, all the things that you don't really learn in school. And here you are as an adult trying to conceive. So you're like, what is actually normal? So what's a normal cycle? A normal cycle really truly can range, but a normal range is anywhere between 21 and 35 days. And then in terms of the length or duration of, in terms of bleeding, is about 2 to 7 days. If you're within that range, even if it varies, it's considered to be normal. The next thing is, what's the average age that someone actually can start with, like menarche, which is your first period. And on average within the United States, it's about 12. There is some difference with ethnicity. So African Americans do get on average a little bit younger, but they're considered to be very, very normal. The other thing in terms of understanding your cycle is a few different definitions. You have to understand what it is, or to have the diagnosis of infertility. So what infertility is greater than 12 months of unprotected intercourse or inseminations, and you're unable to conceive if you're less than the age of 35. That time is shortened when you're greater than 35 to about less than 6 months. One interesting fact when people always think about their cycles and fertility is their concern often that birth control pills can lead to infertility, but they really don't. What birth control pills do sometimes is actually mask different diseases, things like PCOS, or primary ovarian insufficiency, that you didn't know you had because you were on birth control pills that made you normal, if you will, having a normal length in terms of a cycle and the normal length of bleeding. Next slide, please. So I always like to start all my consults talking about the menstrual cycle. As I said before, everything that you were supposed to learn when you're younger, but didn't really get. So timing really does matter. So if you really can understand your natural cycle, you can understand that, there is actually the most optimal time to conceive. And pregnancy really only can conceive within the 24 hours after ovulation or the release of the egg. Interesting fact, sperm actually can live in the reproductive tract for up to 3 days. So oftentimes people say, well, I have to get the timing just right. I have to have intercourse just this day. You do actually have a little bit of a window. So if your partner is out of town, if you will, there is like 3 days. So again, having intercourse before, you still have sperm around for those 3 days that can be around the time of ovulation. And things that can help you in terms of understanding your menstrual cycle and when you're in your most fertile window are things like ovulation trackers. Now, in terms of ovulation trackers, they're usually over-the-counter ovulation predictor kits, or we use the term OPKs. They can be various different brands. Oftentimes what you have is kind of either 2 lines to say that you have a positive. Some people actually get a plus to see that you're actually ovulating, or the other one is the smiley face. And all of them are kind of very similar. They're using your urine to see if you're having an LH surge or about to ovulate. And then some people do also use those kits in conjunction with their apps. There's a lot of good apps out there. Everyone has a smartphone that you can see a little bit of consistency in terms of when you bleed, and then around the time that you would grow a normal egg and ovulate it. Next slide, please. So other than understanding your cycle, number 2, important thing to really understand is understanding the fertility evaluation. So by understanding your fertility evaluation, you can really plan for your future. As Amelia said before, our goal is always to help you build your family and reach your family planning goals and dreams. And you do this by kind of having some diagnostic testing. And in terms of what that diagnostic testing includes, it includes blood work, specifically things like AMH, FSH, and estrogen, as well as an ultrasound to count kind of your resting follicles or eggs, or an ultrasound to evaluate the health of your uterus or your fallopian tubes. In terms of people who have male partners or men, we do semen analysis checks where we look for enough volume in terms of an ejaculate. We look for the count or concentration of sperm, the movement of that sperm, or the shape of that sperm. And then in terms of kind of understanding these results, at Vios, I think a wonderful thing that we have is sometimes you don't think or you don't want to have, intervention right away. And we understand that. And we want to empower you with information so you can understand your fertility evaluation. So we do have something that's called the Vios Pulse. Now, the Vios Pulse is something that's not a full consult, but it's actually looking at your fertility evaluation. It includes things like your ovarian reserve testing, the blood work, as well as the ultrasound. And then you also can get a semen analysis. So it's kind of the really basic things. And it does include actually a brief consultation or phone call from myself to kind of review that testing and kind of find out, where are you at in the spectrum? Is it everything looking normal? Should we start trying now, or would you potentially need consultation and some additional evaluation and potentially some treatment? Next slide. So these are kind of the specific things that we would talk about. So I'm always telling people it's a little bit of a mini consult before you come into the office. So when we do evaluate egg health, or your ovarian reserve, if you will, we look at multiple things. They are mostly your blood, our blood work and labs, as well as a transvaginal ultrasound. Now, AMH, or anti-Mullerian hormone, is a very simple blood test, but it actually reflects kind of your pool or your quantity of eggs, the number of eggs. Now, that being said, it won't tell us the exact number. We'll talk a little bit more about the ovary more, but we won't know exactly how many you have, 50,000, 60,000. But we know, within these numbers, low is considered less than 1, normal or average is 1 to 3, and kind of above average or high is greater than 3. We also look at things like your FSH and your estrogen level. And so that tells us a little bit more about the quality and quantity of your eggs, and also potentially is your ovary resistant? Is there normal function, if you will, in terms of the hormonal ups and downs with your ovary? So a normal FSH is less than 10 ideally, and a normal estrogen level at the exact same time is less than 80. And again, we typically do this evaluation when you're at the very beginning or baseline of your period. It's the most accurate time. It can be on cycle days 2, 3, 4, or 5. And remember, cycle day 1 is the first day of full flow and bleeding. On the same time that we do that blood work, we also do an ultrasound. This is a transvaginal ultrasound because it's the easiest way to see the ovaries, where we look at the ovary and we count up the starting follicles. Now, every single month, a group of eggs or follicles kind of pop up in the ovary, and those are the only ones that you can access that month. So we look at that number again to reflect the ovarian health, or kind of the count that you have every single month, and kind of how many options, if you will, if you have with those follicles. Next slide, please. In terms of outside the ovary, the full evaluation for fertility is looking at things like the uterus and fallopian tubes, because if you have eggs, they still have to meet with sperm in the fallopian tubes. When you create an embryo in your fallopian tube, it has to implant into the uterus. So we do different screening tests to make sure that the uterine cavity is normal in terms of shape. There's no structures in them that would affect implantation. So you can do that with things like a saline or saline infusion sonohystogram. These are typically done in the middle part of your cycle, between day 6 and kind of 12 or so. Where you come into the office, we use a very small catheter that goes into the uterus and fills the uterus with water. And we do a 2 or 3D ultrasound to really look at the whole shape of the uterus to make sure that it's appropriate for implantation and pregnancy. We also will do HSGs or hysterosalpingograms, which is very similar to the saline, but this is an X-ray dye test. It's done at the same time, but we basically put dye into the uterus, and then the dye should go into the uterus and fill it, then out to the fallopian tubes. And you can actually take an X-ray. So you can get a picture, a flat image of, is the uterus the right shape? And also, did the dye go all the way out into your fallopian tubes and spill out? Tubes are also very, very, very important, because if you don't have fallopian tubes, sperm and egg will never meet. And the weird thing is that actually some individuals, though it's a small amount, are actually born with anomalies within your uterus. It might have a half a uterus, you may be missing a tube, and these could be easy reasons why you're not conceiving, and we can kind of optimize those things. If you have some structural issues with your screening test, like on the HSG or the SIS, we can actually oftentimes correct those with a hysteroscopy. And it's the same day surgery that we can do in the office, where we go in with a very, very small camera under anesthesia and can truly identify these areas that could be problems, and we can kind of remove them and improve the shape of the uterus to, again, improve our outcomes. And again, what we're really looking for is anything that would affect your likelihood of succeeding. Implantation of your embryo, carrying a pregnancy and not having a loss. And those things can include things like polyps, fibroids, scarring within the uterus, prior infections, or potentially blockage of fallopian tubes or dysfunction. And again, it's just an overall evaluation of the health of the uterus and the tubes. Next slide, please. Now we want, like I said before, I really do care about male reproduction, because I feel oftentimes they are not talked to at all. Male reproduction is very, very important. And so we still need to do some testing, because as you know, in order to create an embryo, you need to have sperm and egg. So it's very, very important. So we do look at things like a volume. How much sperm is actually getting outside the body? Obviously, if you have a normal number, we are assuming that enough sperm is getting out. But if you have a low volume, the concern would be potentially, is there kind of some structural problem, some blockage? So when we do a semen analysis, we do go by the WHO criteria, which is the World Health Organization criteria. We use the strict criteria, the most recent addition, and you need to have at least 1.5 mLs within your collection cup. The other thing we look at within that volume is you need to have enough sperm, count the concentration, how much is in there per ml. And normal is greater than 15 million per ml. Once you know you have enough volume and enough sperm, you need to know that enough sperm is actually moving. So when you do have intercourse, if you have a male partner, sperm has to travel a very long way, up through the vagina, through the cervix, up to the uterus, and out to the fallopian tubes. It's in the fallopian tubes that sperm and egg meet. So obviously it has to be modal or to move. Percentage-wise, you want to have at least 40% that are moving. And the last thing is the morphology or shape of the sperm. Now, men are very different than women. Women are born with every single egg we're ever going to have, but men are actually constantly making sperm. And sperm from today actually reflects 3 months ago. And since they're making so much sperm, it's not always perfect. So in terms of morphology and shape, you really just want at least 4% to be the right shape in terms of a small head, a short little neck, and a long tail. When there's other abnormalities, we can potentially look at additional things on your semen analysis, like the fluid thickness, acidity, and sugar content. But the most important things that we really look at when evaluating good sperm production is the volume, the count, the motility, and the morphology. In terms of the best time to do a semen analysis, we typically recommend anywhere between 2 and 5 days of abstinence. So that's no intercourse, no masturbation. So you typically would make your appointment, and collection is done within the office, and then kind of plan accordingly. And then for those who are not having a male partner with using a semen analysis, we can still evaluate donor sperm, because when it comes, we actually have kind of guarantees, and we can look at it when we thaw out. And again, we can, give you information about the likelihood of success depending on your sperm. Next slide, please. So why does female age matter so much? So again, this is understanding the fertility evaluation. So as I said before, numbers are very, very important in terms of your ovarian reserve testing, the HSG for the uterine cavity, and then, the SIS for the saline, and your semen analysis for sperm. But what truly is the #1 predicting factor for a woman's fertility? It's actually age. And the reason why is we're born with every single egg that we're ever going to have. Interesting thing, our highest peak of eggs is actually in utero, before you're actually born. But you're born with about 1 to 2 million eggs. And then actually from birth to puberty, you lose more than half of them. So most women at puberty or at menarche, their first period, will have about 500,000 eggs. In between puberty and menopause, every single month, what happens is a group of eggs pop up, just like I said, the AFC or antral follicle count. And that's the group of eggs that your body can kind of draw from. But even though we start with a group of eggs, we only select one as our single dominant that we potentially would ovulate and conceive with. And we kind of throw away the rest, if you will. So, as you age, your eggs and your pool will decrease because you're using them each month. And then also as you age, the risk of an abnormality increases. So in terms of when a woman's fertility starts to slowly decline, it starts to slowly decline around the age of 35. But again, there's a more significant change after the age of 40. And likewise, the risk of abnormalities, what's called aneuploidy, genetic problems within the egg, that again starts to increase around the age of 35, but more significantly after the age of 40. So when you come in to talk to us in terms of the fertility realm, we always, want to hear your age. And it's not that you can't do different treatments, but it kind of helps us in terms of your family planning, because we're looking at how your age might impact your fertility outside just the ovarian reserve testing that we get. One other thing I do want to bring up is also kind of miscarriage. And again, it's age related. So on average, people don't really talk about this. Miscarriage is actually very common. It happens to 1 in 4 people, about 25%. So even at a very young age, if you've had one miscarriage, usually it's due to chromosome abnormalities. But as you age, that risk goes up because the risk of an abnormal egg goes up as well. But again, we take that all into consideration, because if you have anything else that's going on other than just fertility, things like recurrent pregnancy loss, we're evaluating all of that so we can help you build your family. Next slide. So we're bringing us to number 3. We're almost there. So in terms of number 3, things that you really want to know is you want to know that lifestyle factors can impact your fertility. Now, everyone always says, you guys did all that testing, I need to do that. But what can I do? What can you do? What do you have control over? Because, you want to have some control over this whole process. So in terms of things that can negatively impact your fertility, in terms of decrease your likelihood of success, in terms of your response to medications, having good quality eggs, implantation, and even miscarriage, first thing would be things like BMI. So there is kind of a golden area, if you will. So if you're too underweight, or having a BMI less than 19, or overweight, a BMI over 35, it can affect your fertility. Natural conception, it can affect our fertility treatments in terms of the medications you take and how they work on you, and also can be associated with things like miscarriage. So it's very important to have, a healthy diet as well as exercise. But there are extremes. You want to kind of just be in the middle. The other thing that can negatively impact your fertility is smoking. So when I talk to couples, it's very difficult if you're a smoker to stop smoking, but it's one thing that you can do to actually improve your fertility. Smoking, if you actually look at women, if you're a daily smoker, you actually go through menopause a couple years early on average, because it actually will affect the health and the degenerating rate of your eggs. So if you are a smoker, I know it's very, very difficult, and we support you, but it's definitely something you want to quit. And that's any form of smoking. That includes cigarettes, tobacco, vaping, or marijuana. No smoking whatsoever. It is bad for eggs. And yes, men, it also is bad for sperm. It affects radicals in terms of the blood. So again, it affects your rapidly dividing cells, which are your sperm cells. So if you are smoking, one thing that you can do to improve your outcomes is to just stop that. We understand that it takes time, but we're here to support you. So stopping smoking can improve your fertility. The next thing is alcohol. So it's more an overuse of alcohol. Oftentimes we do tell you in the fertility realm, if you're doing any form of treatment, you should probably just stop or negate it because it can impact, again, how you respond to medications, fertility, and outcomes. The last thing is caffeine. Now, I know as a Pacific Northwest person, when I say, how much caffeine do you drink? Everyone's like, I drink a little bit. I understand that there is a coffee house kind of every other block, right? So there is some impact in terms of negative outcomes, in terms of miscarriage and fertility when it comes to caffeine. Positive thing is that it doesn't say zero caffeine. Really, you can have about 1 to 2 cups a day, and that shouldn't impact anything. Anything more is considered excessive, and so it can affect things. But that being said, when I say 1 to 2 cups, I mean, your talls. I'm not talking about your ventis or your grandes. So again, decreasing your caffeine can be something you can do that can impact your life and your fertility outcomes. The last thing that's kind of in there where I start is medications or supplements. So oftentimes when your doctor asks you, what medications do you take? You're like, well, I take ibuprofen, I take Tylenol. We also want to know if you take any supplements. One thing that really can negatively impact men in terms of medications are men that are taking supplements or medications prescribed by doctors that are derivatives or they are actual testosterone. When you actually take testosterone, it can decrease sperm production. And oftentimes a lot of people are using testosterone to help with people's fatigue when it comes to men, libido, etc. So it's very important if we know if you take any medications, any supplementations. And then likewise, other things that can affect your fertility or at least negatively impact it are, if you have anxiety or depression, some of the SSRIs or medications you take can affect libido. And though you don't think that that's going to make a difference, when you're trying to conceive spontaneously, male and woman, you do actually have to have the action of intercourse. So you want to be kind of in the mood, if you will. So we want to know that the medications that you're on, because oftentimes we can kind of suggest, things that might be impacting your fertility that you can either wean off or even transition to a different medication. Now that's enough about negativity because I'm a positive person. Positive things that can affect your fertility in terms of modification. It's actually, again, like I said, with the BMI, having a healthy diet. So there really truly isn't a fertility diet, if you will. But there have been some studies that the Mediterranean diet actually can improve outcomes in terms of just optimizing natural fertility. So you want a diet of rich and leafy greens and vegetables. You want to decrease your saturated fats and really avoid processed foods, okay? And then the last thing, just that easy thing that you can do is just taking supplements or vitamins. So for women, taking a prenatal vitamin, for men, taking a multivitamin. There's been a lot of good studies that CoQ10 or coenzyme Q10, ubiquinol, is a good egg and sperm vitamin. Antioxidants are very helpful in fertility, as well as vitamin D and fish oil. Again, back to the Mediterranean diet, good fish, being a pescatarian. You can have other meats, but fish is very good for fertility. Next slide. So I want to talk a little bit about understanding the importance of family history. I think that's often something that people forget to fill out on your intake form when you're coming to see your doctor. Now, we really think about your family, not so, is there someone else in your family that's infertile, but we want to know things that would optimize your outcomes. So we really want to know if you have, some syndromes are associated with kind of learning disabilities and birth defects. So that actually have some genetic things that affect some women's fertility. So it may affect men a different way than women. So, having family members that have had learning disorders, have had birth defects, we want to look at that because sometimes the syndromes can be associated with fertility. Understanding things like your mother's menopause. I know oftentimes a lot of the women don't want to ask their mother when they went through menopause. Your mom may not want to tell you when she went through menopause, but you do want to know that information because if she went through menopause at 41 and you're 39, you're more likely to go to menopause a little bit earlier versus later, which would impact, again, your fertility, your family building. The other thing I want to talk about is looking at your family history of cancer and genetic disorders. I mean, this can impact you and it can impact your children. So the very nice thing about fertility now is that when we find different diseases or genes, you can actually make some kind of improvement in your outcomes. We do have genetic testing that we can do of your embryos before you conceive if you use things like IVF. So if you carry something like cystic fibrosis, spinal muscular atrophy, thalassemias, we can ensure that, your embryos are either carriers like yourself or don't have the genes at all. And then when you also think about things like breast cancer or BRCA, those are very important because not only they are associated with fertility outcomes, but again, they can affect the lifespan or the quality of life of your sons and daughters. And the last thing I always want to bring up, people don't realize that CF, which is a very common thing, cystic fibrosis, actually with men has been associated with something that's called congenital absence of the vas deferens. So sometimes men have CF, meaning they carry the gene, but they don't have all the symptoms, but they're missing the piping that allows sperm to come out. So they don't have sperm that comes out of the ejaculate, which affects their fertility. And then overall, we do also want to know if anyone in your family has syndromes, because there is a genetic and hereditary link for a lot of things that can affect fertility, such as like PCOS, endometriosis, and even within different ethnic backgrounds, fibroids is very common and there may be a genetic and hereditary component. Next slide. So the last thing is very important to me. One important thing about understanding your reproductive health, or the top 5 things, is understanding that your voice matters. You really want a balance of your goals and expectations to create a comprehensive care plan. And to do that, you need to find the right team, really someone who's going to listen to what you say, understand where you're coming from, so we can work together, again, to help you build your family and reach your goals. And so one thing that I think that sets Vios apart from other people is that we're very patient-centric. We look at every detail that you have, and we really want to make sure that we can build things within kind of your realm. I mean, we're going to give you recommendation on what's best, but we do care about where you're coming from, and we're going to try to get you there so where you're very comfortable. The other thing that Amelia already talked about is we're very, very innovative. We are looking at the newest and cutting edge technology, again, to improve the outcomes for our patients. So we're using things like Zymo, which is a different way to wash sperm that's been shown to potentially improve outcomes when there's DNA fragmentation or low counts. We're also using Violet technology. As I said before, I'm very invested in fertility preservation. So this is a non-invasive way to actually look at eggs and talk about quality, because really we only can talk about quality of embryos. We can do genetic testing. Well, what do you do with the eggs? I haven't made embryos yet. I'm not comfortable making the eggs. Are they good or bad? So the Violet technology is a way to give you more information to help you kind of plan for the future. And I really do think that our staff, I love both Taylor and Amelia, are very just experts in empathy. They really do care. We really do care about, how you feel, where you're coming from. And we're very committed to providing care to kind of everyone. We want to treat everyone. In general, Vios is in network for a lot of insurance companies. We do have a lot of flexible financing options. And, we are centrally located here in the Pacific Northwest, and we have clinics in both, the Illinois area. We have them in Wisconsin as well as St. Louis, and we are ever expanding. And we understand, through the pandemic, we haven't get to see your, lovely faces, but we've really taken advantage of telehealth appointments, again, to optimize your treatments. We can talk about things very easy so we can be more efficient and streamline your care. Next slide. I'll let you go, Taylor.
Okay, man, I could just listen to you talk all day about fertility, and I'm sure everybody else feels the same. Kind of how, Dr. Adams said, we do offer a full range of treatments, whether it be the least invasive, so to speak, whether that be timed intercourse at home, and we just do some monitoring, all the way to, using kind of out of the box ideas such as donor embryos. If you want to, take an embryo that's already selected, go from can't talk, go and pursue pregnancy that way. We have everything in between, IUIs, IVF, really your testing, and then Dr. Adams' recommendation. It's going to guide us in whatever path. And we can always, start down path A, whether that be IUIs, and then say, okay, let's take a change, go to path B and go to IVF. And, we will take you through every step of the way. You're going to get to talk with Dr. Adams and I a lot. You might get a little sick of us, but that's okay. We'll be here for you. And we'll just go through every question you have about each treatment cycle. And I think next slide, we had to have some questions. Some were sent in early. If you guys have any questions, just write them down in the chat, and then I'll kind of go through them, and Dr. Adams or I will answer them. The first question that came in early is, when is a good time to see a fertility doctor? Is there a particular point in the cycle? And do we have to be referred by another provider? Dr. Adams, you want to take the lead on that?
Sure. Well, that is an excellent question. So as I said before, when I talked a little bit about fertility, you can always have early evaluation, because some people are not really sure and they want to, again, plan for their future. So something like a reproductive checkup, like the pulse, is very, very useful, especially for women who are single and are not sure if they want to do fertility preservation, or if they think, next year I'm going to probably start with my partner to try to conceive, or I'm using donor sperm next year. You can do the fertility checkup. You can do early evaluation before you start because it gives you more information. In terms of couples that have been trying, or what people who have been doing inseminations where they're in another office with your OBGYN or at home, and again, it's age related. So if you are less than 35, and again, you've been trying to have timed intercourse or inseminations for more than 12 months, then it's a good time, if you haven't been successful, to come in for some evaluation to see if there's anything we can do to change or optimize or increase your likelihood of success. Again, that time frame is dropped down to 6 months if your age is greater than 35. In terms of kind of the best time, if you really want to time things perfectly, a good time to actually make an appointment with the provider or myself would be kind of at the end of your cycle. As I said before, when we start your ovarian reserve testing, it is time sensitive, meaning it's done at the very beginning with your period. So oftentimes I like to see you kind of go over everything. And then if you have your period in a couple of days, it would be optimal, because then you would come in for your ovarian reserve testing. So that would be the blood work and the ultrasound. Then we would be able to do your saline or structural stuff in terms of your SIS or HSG. And then hopefully before your next period, we would have another consultation and potentially could streamline into treatment with the period after that. Now, for women who actually don't have regular cycles, that's always the thing that happens. If you have irregular cycles and a regular cycle greater than 35 days, or maybe you get a period once every 6 months, you really truly can do diagnostic testing at any time, because we can figure out where you're at in your cycle, or if you're just kind of hanging out in the beginning, if you will. For example, women who have like PCOS or polycystic ovarian disease oftentimes have irregular cycles. And kind of what they're doing in terms of the length of the cycles is hanging out in the beginning, because they're not really growing the egg. The eggs are there, but they're not growing. So you can come in and have random kind of evaluations. If women are doing things like fertility preservation, if you have things like Nexplanons or IUDs in, that's another good thing. You're a lot of times suppressed. You can kind of come in at any time. If for some reason you're not in the beginning phase, we can at least figure out where you're at and let you know when your next repeat evaluation would need to be done.
Lovely. We have another question. So they're wondering if you can talk a little bit about working out versus fertility, and then timing, especially for the athletes. I feel like we probably have some runners and people wanting to probably know about when do we need to decrease or increase exercise within the cycles that we're doing.
Okay. Well, it really kind of depends on what kind of cycle you're doing. So if you're doing things like natural cycles with inseminations or timed intercourse, or you're doing ovulation induction, which is usually with oral medications like Clomid and Letrozole, you're fairly good in terms of working out. We just kind of recommend after your insemination or timed intercourse, maybe taking it down a notch in terms of keeping your heart rate up too high. So maybe not going directly to Orange Theory a day after your IUI. Maybe just go for a nice light jog. You don't really need to push it up into the orange or the red. I don't really know Orange Theory, but it's, go really high intense. We don't need to really hit right away. In terms of IVF, it really is important in terms of timing. So, I consider myself a little bit, I used to be an athlete. I try to still stay in shape. But if you're doing IVF, you really do need to do a little bit of planning. We have had some marathon runners in the past. You don't want to do IVF right before a big marathon. You want to kind of do it afterwards. And the reason why is when you're taking the hormones specifically for IVF, they're injectable and you're growing a lot of eggs. So there is a risk of something that's called ovarian torsion. When you have your big ovaries, you don't want to be jostling them around. So you're not doing any HIIT training. You're not doing any running. You're not doing any burpees. You're not doing any kind of plyometric movings, but you can walk. You can do light yoga as long as you're not doing inverted poses for my really good yogis out there. You can do resistant training as well as weight training. It's really, again, the bouncing effect. So oftentimes the people who are doing those things, whether they are, runners, they play soccer, basketball, you want to do it in an area of time where you would have at least about a 3 to 4 week period of time that you can't do that vigorous activity, if you will. And oftentimes we can work around your schedule because we're really trying to plan that. So you get all your evaluation done and you're like, okay, next month I'm planning for this marathon. Where's my cycle going to be? So we can plan to where you can start right afterwards, recover, and then get ready for the next marathon.
That's the beauty of fertility. We can always try and time things.
Mm-hmm.
Just for a little generic question, what does Vios stand for? I actually looked this up when I first started with the company, and it does mean to move forward. So, we're constantly in fertility, changing, moving forward, keeping up with this technology, and then helping you guys pursue your path forward in whatever your fertility journey might be. And then let's see here, we did have
Oh,
another
I have one more thing.
question.
Don't forget
Oh,
the
yeah.
other part of with that one, because Vios can mean multiple things. Remember, Vios is also a Greek word. So, you know, Dr. Beltos that we work in conjunction with, it's Greek, and she started the company. It's the Greek word for life. And so life is also very formative, moving forward, conception. So it kind of keeps all those positive vibes that we feel every single day, kind of puts it all in one, Vios.
I love it. Next question is, does Vios have a support group or counseling to help deal with the stress of infertility? So I know that we do have quite a few recommendations of site counselors that can be very supportive in the fertility journey. And I know there's quite a few Facebook groups, blogs, all sorts of things. Dr. Adams, do you know if we have a direct link to any of those support groups?
There are some more that are available kind of during telehealth. So oftentimes it kind of depends on what you're looking for. Again, it's the customization of care. Is it you want to be in a group function, or do you actually want to get a therapist that is associated with fertility? It's very, very difficult to go through this process. A lot of different personal emotions and feelings. So what we really want to know is kind of where you're coming at. Is it just that you want to be linked up with other women who are going through this process, or would you like someone locally or potentially even through telehealth that you could just talk to without any kind of expectations, if you will, getting all your feelings out, if you will, and we can help you with that. And also outside of that, you know, I am a very big proponent for acupuncture. I think it is a great way to kind of relax your mind and your body and to center yourself. And we do love a lot of the local acupuncturists, and we can kind of guide you to people who would be very helpful to help with that stress and anxiety.
Yeah, that was a question. And acupuncture also has a dual side effect of it helps increase, blood flow to the uterus, which is always good when you're pursuing pregnancy. And then I don't know if anybody saw in the chat, we are partnered with Fertility Rally. It's an online membership of support for fertility through early pregnancy. And that's when, if you're pursuing pregnancy, we see you through your about 10 weeks of pregnancy and then go off to your OBGYN. So Fertility Rally can be with you, through the entire time you're with us. Mm-hmm. And then it looks like there was a question regarding Chinese herbs and fertility, Dr. Adams.
Yeah, I'm very much a proponent, again, from a more comprehensive and holistic care. I don't think there is just one answer, if you will, and it may be just because I'm from, I'm a West Coast girl, Northwest girl. So in terms of Chinese herbs, they can be very helpful in the fertility process, as well as acupuncture. In terms of me, I just kind of want to know who your acupuncturist is. And I would like to know that your herbs that you're on, because again, I just want us to all be on the same page and working together. And I'm very open to collaborative experiences.
I love it. It's beautiful. Is there any other questions that anybody would like to pose in the chat? Obviously, you're going to be talking to us later, hopefully, and can always ask questions through your portal or calling Vios, and you would likely get to talk to me.
Mm-hmm. I think that's it. Okay. Well, I think that's kind of the end of our first little webinar. Hello, welcome. We love you all. Vios Pacific Northwest, the Portland, Oregon, and Vancouver, Washington area. We hope that this is going to be a start to a very wonderful experience with us, and that's filled with, again, patient-centric care. We hope to expand over the next year so we can really serve the entire community and everyone that's around here. We're really open to what you guys' thoughts are, things that we can improve. I think that's another thing that I really love about the Vios practice is that, we want to be better. So we do rely on you to help us navigate that as well. So thanks so much for joining us tonight. And we hope that you stay in touch. We're not too far. We're just north I-5. If you take I-5, if you're North Portland person, exit 7A, we're right next to Salmon Creek.
If you do 205, we are exit 36, if you're curious.
Yeah.
Many freeways lead to Vios.
Right. Always lead to Vios.
We're just off the freeway. It's a quick drive. I love it. I love it. And in the morning, for those of you guys who are coming from the Portland area, it's against traffic. There's no one out there. All right. Amazing. Well, with that, I guess we'll just say good night, and everyone rest well, and we really hope to see you.
Thank you guys
for coming.
Bye.